Hello, everyone. We'll get started shortly. Gonna let a couple more folks trickle in. Well, hello, everyone. Thank you for joining us for our substance use and treatment service training. Quick intro for myself. My name is Sadaka. I'm from Home Base. We're a nonprofit technical assistant provider. We provide TA for COCs across the nation. We work closely with Santa Clara County's Office of Supportive Housing. And one of the many things we do in that scope is bring you trainings on behalf of OSH. We are currently looking to improve our training, so we will be popping in a feedback form specific to this training in the chat later toward the end of that training. So it would be really helpful if some of you can fill that out, and then also help us tailor our trainings in the future and ensure we're getting you all the content and topic areas that you want to learn more about. And then in terms of tech, I know you all are familiar with Zoom by now, but I do want to let you know that we are recording this training. All training materials will be sent out and will be posted to the CoC training website. So don't feel like you have to screenshot the slides. We're going to keep everyone on mute by default, but there will be time at the end to ask questions by unmuting yourself or asking questions in the chat. Please feel free to pop questions in the chat at any time. And then we have a group of folks who are presenting today that I'll quickly introduce that will also be able to respond in the chat. And we have closed captions available. So if you hit closed captioning, you should be able to see them. And if you have any tech issues, you can email me directly at sadaka@homebaseccc.org. And then just to get started, if you all can type in the chat your name, the organization you're from, and if you could have any superpower for a day, what would it be? And I will be introducing our trainers today. We have four. We have Dr. Cheryl, Mike Thompson, Tessa Watson, and Roxanne Butterfield that will be presenting today. And I will change screens. Can you all see the slide? Let's see.
Yep, you're good.
Dr. Cheryl, there you go.
Should I start, or do you want me to let people, I guess they can start putting in their superpowers as I speak. Great to meet you all. My name is Dr. Cheryl Ho, and I'm the Behavioral Health Medical Director for Substance Use Treatment Services. I think just as a context, I want to say Home Base and all the work you do is very near and dear to my heart. Because over the past 20 years, I was a physician with the Valley Homeless Healthcare Program, providing primary care for folks that were unhoused, and was part of the team that went to sometimes the backpack or the shelters, different mobile units, permanent supportive housing. So really, really glad to be with this group today. All right, we're gonna go to the next slide. So what I'm going to focus on is I remember being a frontline clinician for people experiencing homelessness, that there was, there's a small window at times when folks want to get into substance use treatment services. And I remember sometimes not always knowing what the resources were that were available. And so my hope today is not only to represent what, my new department, which is substance use treatment services, has available, but really kind of giving a county level overview of what resources are here. I'm also, I've also asked my colleagues, also in my department, behavioral health as well as public health, to also share about for kind of different approaches around harm reduction and what's available in the county as well as giving an Narcan training today as well. That's going to happen. I think just really the idea is, and I know that you all are do this every day, but really meeting folks where they're at. And we just really want to give you the tools and resources to meet folks wherever they're at. So I'm going to really be focusing on the treatment side. And so this is really for folks, that are thinking about treatment, that are interested in treatment. And the big players in the county for most of our patients are, the behavioral health department where I work now, which is where we provide substance use treatment services, Santa Clara Valley Health, which is Valley Med, O'Connor, St. Louis, all the clinics, as well as Valley Homeless Healthcare Program, and then public health, who's really going to talk about their harm reduction program. And so you'll hear more from them today as well. So next slide. All right, so first we're going to do a deep dive into what I call SUTS, or substance use treatment services. So there's a continuum of care, and I have to say, until I joined this department, I was really only familiar with kind of what we call detox or withdrawal management in residential, because this is where I think the focus of where folks are who are unhoused are really accessing the services. But I also wanted to let you know there is a network of outpatient clinics. There's intensive outpatient, once a week outpatient. There's our methadone clinics. And those provide counseling for folks that are really looking for treatment for their substance use disorder. And then on the other end of the spectrum on the right, there are recovery services. So once folks are, in a period where they want to, maintain a kind of a recovery model, there are recovery residences. And I think, to be honest, this is not often access service that our kind of unhoused partners, service partners know about. So we'll talk a little bit about all of these. So next slide. Okay, so we will talk about this, but I think this number, either the 988 or the gateway number, I'm gonna be upfront and honest. I think this has not always been, what shall we say, maybe the best way that our patients or our clients like to access services, right? I think there are so many 1-800 numbers out there, and this is not one of our exception, but I will say that the gateway is a gateway for both mental health and substance use treatment services. I'm going to give you some tips as to when you need to call gateway and when you need to not call gateway. And I think the big pro tip that I have for you all today is, I think from what I remember, for most of the people that are seeking services coming from the homeless spectrum, you're really looking for withdrawal management and detox, and you don't need to call gateway for that. And so I want to kind of give you that freedom that you don't have to access gateway if you want to do withdrawal management or detox. And so, I will give you the info on, who those people are and who you can contact directly for that. So go ahead and next slide. All right, this is your cathartic moment. So if you have had good or bad experiences, I want you to put them into the chat here. And what has been your experience? And I'm okay. I'm a big girl. I can take whatever you have. You can just put it in here, and this can be your moment. I do see a raised hand as you guys are typing in the chat. So Linda, do you want to unmute and go ahead?
Thank you so much. Thank you so much, Dr. Ho. I just want to say I'm with San Jose State University, and some of the things that we're dealing with are students that are coming in that are dealing with substance abuse issues, and it's affecting their academics and, being able to study and just perform like they should. So they may not be homeless, but they're definitely dealing with overuse of alcohol and drugs.
Yeah, and so I definitely thank you for calling that out. I want to say that these services are for all. I will say that I am focusing primarily today on Medi-Cal-based services. So some of the services we'll talk about are for Medi-Cal, and some of the services are for anyone. So I would say that the SUTS services that I talk about today are really strictly for the Medi-Cal population because Medi-Cal does pay for these services. And when you have private insurance, I have to say that sometimes the services are not as, I mean, this is weird, but you don't have as many services. So I think you have to find your own path in terms of the access to, residential or, for detox. And so, it may differ, but the services that public health will talk about is for all. So regardless, yeah.
And we see them all, Medi-Cal and private insurance. So we get everybody that has everything.
Yeah, so this is a good distinction, I think, to
Mhm.
know that mostly we're focusing on Medi-Cal except for public health, who serves the entire population. So I see in the chat that some experiences are that, the services are siloed, they're changing, they are very segregated. That is true by binary gender categories. Difficult to connect clients is. It can be frustrating, and that is what I hear, and that's what I used to call these numbers with the patients, and I would be very frustrated with them. Part of the reason why I decided to join this side of the house is, really to help demystify and to make things better. Yeah, especially if you're using undergo psychosis. And so that you bring up a really good point for people that have what's called co-occurring disorders. So when you have an active mental health and substance use disorder, I think what I see frequently is that everyone's kind of doing this, right? They belong to you, and no one just sort of takes care of the person that's needed. Lack of available beds, 2 months out, actually okay, I'm glad you had one positive experience. That's good. So yeah, I mean, I think this has been, my experience as well, is I think I will just be upfront and say that I think that for a county our size, we don't have enough beds. And we are working on that. So the county is working to bring more beds online. Can't happen soon enough, but we're looking within the next 1 or 2 years to bring out more beds. And so, I think, and we're also working with our existing contractors to be more open and taking patients at the time that they need the service. Okay, thank you. For if any more cathartic responses, you're welcome to put them in the chat too. Next slide. Okay, so I'm going to kind of do a deep dive into some of these services, and you're also welcome to put questions in the chat or ask questions. So I'm first going to talk about outpatient, and I know this is probably going to be less relevant for people in homelessness because I just think it's really hard to make an appointment that you keep on the same day every time, every week. But so I'm just going to put this out here just really more, just so that you have that knowledge. So there is different levels of outpatient services. There's outpatient, which, generally is, either a group or individual, and it's usually 1 day a week, can be delivered through telehealth or in person. There is something called intensive outpatient, and this requires someone to show up 4 to 5 days a week. And this is someone who needs a little bit more intensive care, but maybe not at the residential level of care. And, I will say partial hospitalization, we don't, really offer that, but just so you know, that is part of, the spectrum of services that could be offered. And so when outpatient, you have group and individual counseling and some targeted case management. And so, those are the types of services that are available for outpatient. And so that's next slide. And so I just want to give you the different resources available for outpatient. So the County of Santa Clara runs 2 different sites. There's Central Treatment, which is located at our Lenzen site, which is, off the Alameda in San Jose. They have an outpatient setting there. We also have the Reentry Resource Center. So folks are probably familiar with the Reentry Center, which is really located, off Mission Street near the main jail. And at that site, it's really, there's a focus for folks really coming out of the carceral setting. And there's a reentry resource center where you can get all different kinds of resources. And you can access outpatient substance use treatment services there as well. And at that particular site for SUTs, you don't necessarily have to be, within the carceral system, although that tends to be who is there. Next slide. The county also contracts with a number of contracted agencies. that are also eligible for anyone on Medi-Cal as well for outpatient services. And so, they have different locations depending on where you all are located. Health Right 360 is located off Tully Road. We have Caminar, which is off of First Street. Pathway, which has a footprint both in Santa Clara, a little bit more north, as well as south in Morgan Hill. And then Gardner in downtown off of Virginia Street. And so, I know that you'll get these slides, but you are free to call these folks directly and book an appointment at any of these sites. You do not need to go through Gateway. So again, want to free you of the 1-800 number, and you can call directly to these clinics. Next slide. So this, I think, is really where the money is for folks, I think, that are homeless service providers. So, there's what's called withdrawal management, which I think, most people know as detox. And there's also what's called residential, which is really that 30 to 60 day of that longer intensive treatment. And so, from my experience, most people, you're just trying to get them into detox because they're trying to detox off their substances. And then from, once they're detoxed, then they have to, then kind of, you have to then be qualified or, then have to access the residential after that. So kind of, I like to think of them happening together, so withdrawal management or detox is usually a 5 to 7 day intervention, and residential is that longer 30-day. Let's go ahead and do the next slide. So I wanted to kind of give you a lay of the land as to who the contractors were for detox, as well as for residential. So if you look over here on the left, I think you guys are most familiar with Pathway House, which is downtown, and Mariposa Lodge, which is up in the hills. So Pathway is, identifies as taking men, and Mariposa for women. There is Telecare Mural Right and Momentum Parisi, which is for women and children, and Horizon Cherry Hill. So what's interesting is these top three are within the county, and the lion's share of beds are really here at Pathway and Mariposa. And you can call them directly. So I used to just Google the numbers for Pathway House and Mariposa and just call directly. So you can do that for detox. Mural Right has fewer beds, but you can call them directly. And then again, women and children, or women for Momentum Parisi. And then Horizon. So Horizon Cherry Hill is located in San Leandro, which is quite far, but I know that they have been well known to take or be a little bit more open in their intake requirements. And so that's an option that is available to county residents. So we do pay for beds over at Cherry Hill. So just so you know, the county does do that. And so that is open to folks. There's also Palm Avenue Detox in San Mateo, which temporarily is unfortunately shut down by the state, but they hope to get back online in the fall as well. And I have to say, I just got word that Parisi was also just shut down by the state for licensing issues, but hopefully online back soon as well. And then in terms of residential, which is the 30 to 60 days, there is the Pathway House, Mariposa Lodge, Parisi, and Telecare as well. So these are the places where you can have that longer 30 to 60 day treatment. Do you guys have any questions? Okay. We already talked about outpatient. And we'll talk a little bit more about medications for addiction, but these are the different methadone clinics that are available, and I'll talk a little bit more about that at later slides, but there's 3 that the county run. This is near Valley Med, this is on the east side behind Regional, this is in San Martin, and then BART is over in Menlo Park, but also available to our patients as well in Santa Clara County. We also have a number of recovery residences, and so that is for folks that are open to outpatient, and this is like a 90-day sober living environment, and that is available to folks that are in the outpatient programs. So, Annette, I see your hand raised.
Yes, I have a question. Can you hear me?
Yes.
Okay. Did you just say that Momentum Parisi was closed?
So what has just happened is they are still, you know what, maybe I should just pause here. They're still going to be taking patients. I think we're still figuring out. I think there's a licensing thing. Maybe I'm jumping the gun and that maybe it wasn't announced. So just say they're still available. I sometimes am guilty of maybe jumping the gun too quick. Let's just say for the purposes of this presentation, Momentum and Pre-C is still in operation. I think I think nothing is, I'm sorry, I should not do this before a large group. I think they're open. Just I think you can call them. I think there's some things that are happening behind the scenes right now, but they're open.
Okay, thank you.
Unless
for
we hear
clarifying
otherwise.
that.
Yeah. Just to clarify, for detox services, you can contact facilities directly, but for residential, you have to call Gateway. Yes. And that is because the 30 to 60 day for residential requires Medi-Cal to approve that. And so you do have to call Gateway for authorization for the residential treatment. So what I would say is for your patients, get them into detox, but at the same time, go ahead and call Gateway for approval for residential. Yeah. Next slide. And then there's a whole other set of contractors for for youth. So when you're 12 to 21, they have a separate set of outpatient contractors. And then if you need residential, we contract with Scotts Valley, the camp, for residential beds for youth. And then there's also some juvenile justice service as well. Next slide. Okay, so that is the SUT system of care. I'm going to transition to what the county health system has to offer. With any additional questions on the SUT side?
I
Can
see
we
one in the chat, Dr. Ho, about are adults able to access the camp in terms of Medi-Cal beneficiaries?
So the camp for Medi-Cal is only open for youth. It is not open for adults. So for adults, it is Pathways, Mural Right, and Parisi, Momentum House on the Hill only. Okay, so I am going to transition us to what is to offer for folks with substance use disorders at the whole county healthcare system, which is O'Connor, Santa Clara Valley Medical Center, and St. Louis. So next slide. Okay, so there are a set of outpatient clinics that you all may or may not be familiar with. This is some of the list of some of them. And then we also, I think, which is probably most applicable for you, there is the Valley Homeless Healthcare Program. And this is one of their signature mobile units that goes to many different sites. Next slide. Oh, someone's not seeing the slides. Is everyone else seeing? So I'm just pausing here, and I wanted to make sure that you all knew about Valley Homeless Healthcare Program. And so I want to check and ask with you all in the chat, have you had an experience, or did you know about Valley Homeless Healthcare Program? Did you know about their different sites? And if not, I would be happy to, I think I am going to share a little bit about what they do. Okay, you didn't know. Okay, I'm glad that we're going to talk about it then. No. Okay, this is perfect. I'm really glad. Maybe they should, yes. Oh, some people do, yes. You take them for verification of disability, reentry center. Heard about it, never heard of the program. Okay, perfect. Yeah, so I want to go ahead and next slide. So since you all are homeless service providers, you absolutely need to know about the Valley Homeless Healthcare Program. This was where I used to work before. And what they are is they provide primary care health services for people experiencing homelessness. And I know, we had provided home base with their schedule of clinics. And it is all on a walk-in basis, really, to meet the needs of the population. And we provided that schedule in English, Spanish, and Vietnamese. So we will, hopefully you guys will be able to get a copy of that at the end of this presentation. And so as long as they don't say, hey, I have a primary care doctor somewhere else, they are welcome to go to any of these sites. And, if Homebase decides that this is what they want, I mean, we could have them come back and do a presentation with you all about their services. But they have a couple of fixed sites. So there is the Alexian Clinic, which is behind Regional Hospital, and then they have a shelter clinic, which is located at the Picardo Reception Center, also known as Little Orchard. They have, I'm sorry, not accurate. They do not have a Bill Wilson clinic. They have a Hope Clinic, which is in downtown for folks in permanent supportive housing, but anyone can also access that site. The only limitation for folks at all of these sites is you do have to be either homeless or have a recent history of homelessness. They have a couple of mobile sites at the reentry center. They have medical mobile units that go to, the Sunnyvale Home for Shelter, the Compassion Center in Gilroy. They have a migrant farm worker van. They have a teen van, which goes to continuation high schools across the county. They have a very robust street medicine team, which goes to a number of encampments across the county on a regular basis. They have a medical respite program. So if someone who is homeless, experiencing homelessness gets released from the hospital, they can stay at a respite program, and the different hospitals contract with this, and you can stay for, a week to 2 weeks, and not be directly on the streets. And we also have a patient outreach arm. And so I would say at all these sites, you can access medications for addiction treatment as well as primary care. They have a gender clinic at their Alexian site, and they work closely if folks have criminal justice focused at their reentry site. So really just, I think I would say out of all the services at Valley Med, they really try to meet patients where they're at, really understand kind of the challenges that people experience in homelessness. They will sign those general assistance forms for people to get general assistance money without having to show up to work. I mean, so, I think they really try to be a warm and welcoming place for people experiencing homelessness. So I would say this is where you guys need to send your folks if you didn't know. When you say the requirement is that they have to be homeless verified, they just take patients at their word. So you do not need ID or anything. You just need to give your name and date of birth and tell folks that you've been homeless, and you're in, and so it's really tried to be as low barrier as we can. So any questions about VHHP?
I don't have a question, but I just wanted to add something about the medical respite. If folks aren't aware and you have a participant that identifies as trans or gender diverse and is in the process of getting a gender affirming surgery, they also qualify if they're Medi-Cal in order to stay there post-surgery, because that's been a need, for participants I work with. So I've recently engaged with that, knowing that that is a great resource for folks, needing surgery recovery.
They really aim to create a safe space at the gender clinic, do provide hormones, and so that is, and it's a closed clinic that happens on Monday mornings only, and so no other clients except for the gender clinic clients will go at that time. Yeah. All right. Next slide. All right. And so I am not going to go into the huge overview of public health. I had created these slides before I knew my public health partners were going to be on here. So I'm going to just push through these really fast, and public health will talk about more about these. So next slide. I will not talk about your mobile syringe exchange program because you were going to do this. So I'm going to just push through here. But just to say that at each of your, at the different, and I'm sorry, I think I might have labeled some of the programs wrong, but you can access medications for addiction at each of the different syringe exchange sites, and they will link you with telehealth partners. And I know you're going to go more into that. So I'm going to go to the next slide. I know you're going to do this as well. These are the different sites that are located for that. And again, I'm just going to go to the next slide. Okay, so we're going to do Addiction Medicine 101. So just so you all know what is available to folks with addiction disorders, I'm just going to do a quick overview of the different medications out there. So next slide. Oh, okay. We can try this if you guys want. What comes to mind when you hear about medications for addiction? And we're going to do a little word cloud just for fun. This works great. If not, that's okay too. So what is it? Menti.com. Use this code, and and then just there'll be a word cloud on the next slide that you guys will see. And if there's kind of things for to see when you think of medications for addiction, what you guys think of. And then do you show the word cloud now? And then to see what's, let's go back.
Can you go back to the slide? Sorry.
So, yeah, people may have missed that.
I'm gonna pull it up really quick. Give me a second, and I'll just show it on the Mentimeter so it's easier for folks to follow.
We just have to do something different, and if it doesn't work out, totally okay too. So, 'cause I know these Zoom things can be a little long,
Yeah, a little tricky.
monotonous.
Can you all see my shared screen? If not,
Not anymore.
Not yet.
okay. How about now? Do you see the Mentimeter?
Yes, I see your slide that says use the menti.com. I'm just going to type that into the chat. Menti.com. Code. I don't know if we can see the Menti slide though.
Oh, you don't see the Menti slide. Okay,
Yeah.
let me try one more time. It should pop up. Sorry about that.
No, you had it a second ago.
Do you see it now? Does everyone have access to
It has
seeing
the QR code, but it doesn't show the word cloud.
We could,
It
You
sees
can
see the
if-
join.
Oh, okay. What about now? Let's see.
Okay, there we go. What comes to mind when you hear about medications for addiction?
There we go. We see some
Methadone. There we
responses.
go. Thank you. Suboxone. Well, you guys are on it. Abuse of narcotics, accessibility. Yep. Suboxone. Vivitrol. Naloxone. Buprenorphine. All kinds. One addiction for another. Yeah, unfortunately, that's how some people. Stigma. Methadone. Barriers. Okay. Science. This is good. All right. I think in the interest of time, so that I can let my other full partners here present, we're gonna go back to the slideshow. Thank you, and continue from there. Thank you so much for doing that. I know it's kind of a weird side.
I don't keep it here, but it's in the storeroom.
All right, medications for addiction treatment. So kind of four main categories, and I'll be talking about the different medications briefly that are available. There's for opioids, alcohol, methamphetamines, and tobacco, which I think most people are familiar with the latter one. And we're just talk about each one just real quick. So, and so I just want to let folks know, I think medications are an important part of treatment for addiction. I think especially for opioids, they are really, really significant in terms of helping people who are seeking recovery. I think the other ones are less utilized, but I wanted you guys just to know about them. So next slide. This is a kind of scientific slide, just to say that there are three main medications for people with opioid use disorder, and that's methadone, buprenorphine, which is also known as Suboxone, and naltrexone. And I really just want to focus mostly on methadone and buprenorphine or Suboxone, because studies have shown that when people take these medications, you have like a 50% reduction in mortality, meaning like 1 in 2 people's lives are saved after you start these medications. And so I know there's a lot of stigma in recovery communities around this, but when I look at the science, this is more powerful and more life-sustaining than aspirin in a heart attack or chemotherapy in cancer. I mean, it is really, really powerful when you look at number of lives saved when people start taking these medications. Naltrexone, also known as Vivitrol, is not for everyone. For some people, it doesn't. For the majority, it doesn't kind of help with the cravings in a way that methadone and Suboxone do. Next slide. Okay, so I kind of just wanted to do a side to side of methadone versus buprenorphine or Suboxone. So if you all are familiar with methadone, and this is sort of, a product of, the war on drugs, Nixon era, where, you're criminalizing, substance use. And so it's really offered in these very highly regulated federal oversight, state oversight treatment programs called the methadone clinics. And these are the only clinics that can administer and give methadone. And, they have lots of rules and regulations, like you have to go daily. And so a lot of times they're open like from 6 a.m. to 10 a.m. And, someone needs to watch you drink the liquid. And then if you, are kind of participating, with the program and, give urine drug screens that are negative for opioids, then you can get some take homes, but highly regulated program. I have to say the medication is very, very effective. And in some cases, some people find this more effective than, kind of the sister medication of buprenorphine or Suboxone. But the downside of it is this high regulation around it. Now, there are movements in the federal government, for it to be loosened, but where it is right now, it's really not. Earlier in the year 2000, there was a medication called buprenorphine or Suboxone that was FDA approved. And the beauty of this medication is it can be given by any prescriber. So that's why it's called office-based. So any primary care doctor, emergency room doctor, urgent care doctor can prescribe this medication. I think what is kind of hard and sad is that even though every doctor can prescribe it, the majority of them don't. And some of that goes to the stigma around substance use. And I think there's also some fear around prescribing this medication. And, I think a misunderstanding of, of who can prescribe it and how it can be prescribed. This medication can, when you prescribe it, it comes under the tongue, and it's like either a tablet or a film. And there's also a monthly injection. So there's different formulations. I find that often for our unhoused individuals, the monthly injection is easier because you only have to remember it once a month as opposed to remembering it every day, and it doesn't get lost. But, really whatever the person wants, whatever your client wants is really the best way to go. The beauty of this medication as well is, you can just pick it up with a prescription for a week supply, a month supply, and the overdose risk of that is very low. So if you take a whole, bottle of Suboxone, you will not die, versus if you take, a month's supply of methadone, you will die. So there's a safety built into this medication. Any questions about these two important medications? Okay, next slide. And so there's a medication that you all may have heard of called Vivitrol, or injectable naltrexone. I probably have really heard it around alcohol. So for folks with alcohol use disorder, it does decrease the number of drinking days. But Vivitrol could also be used for people with opiate or methamphetamine use disorder as well. So next slide. For alcohol use disorder, there are three kind of main medications. One is naltrexone, which could be in the injectable version that we just talked about. It could be a pill. There's a medication called acamprosate, which you can take. The only problem is it's 2 pills 3 times a day. I don't know how anyone can remember to do that. It's not, so I don't generally prescribe it for folks experiencing homelessness, because that is just too many pills to remember, but it's an option. I just want you guys to know about that. And then there is a famous medication which makes you sick if you ingest alcohol while you're taking it. Next slide. For methamphetamine, which I know is very, very prevalent in our county, there is an evidence-based intervention called contingency management, where you provide where there's incentives for urine drug screens that are negative for the stimulant, either methamphetamines or cocaine. Right now, our county only has one contingency management program, which is offered by Health Right 360 off of Tully Road, and that is their phone number. And it is a covered benefit under Medi-Cal. So I am working to try to get this benefit and this program at as many sites that I can. And so I'm hoping in the next year or two, you're going to see a lot more. But basically, people will receive gift cards for negative urine drug screens, and up to a maximum of $599 per year in incentives. And so that is, I think, a real underutilized thing that we have in this county. Medications for methamphetamine use disorder, I think the biggest one that has some evidence is bupropion or Wellbutrin combined with Vivitrol together. And that has shown reduction in methamphetamine use. And then people also use Remeron for methamphetamine use disorder. Next slide. So where can you go and get medications for addiction treatment? So in theory, everywhere, but I think we know that that doesn't happen. So really kind of the main places are, so on the SUT side, each of the methadone clinics offer medications for addiction treatment, including the BART in Menlo Park, all the emergency rooms in urgent care. They know how to do the medications for addiction treatment. VHHP should be your go-to friend. Every single prescriber will prescribe MAT, and they're very good at it. And I think they have some of the highest expertise level in our county. And so I think this is especially pertinent for you all. And then our public health partners will talk about as well today, where you can get that as well. Next slide. That is it. Any questions about MAT sets?
Yes, I have another question. Okay, so did you say that they're going to be offering gift cards for every dirty bottle?
Every negative, every clean. I mean,
Okay,
I don't
okay.
usually call
I
it
was
clean. I
like-
call it negative for the substance.
I was like,
yeah.
okay, thank you.
Yeah. Oh, thank you, Tammy, for saying that there's also MAT in custody and juvenile hall. So within the custody setting, people are offered the long-acting injectable Sublocade. Yeah. And pediatrics, for pediatrics, adolescents, you can just get directly admitted to the hospital for starting onto Suboxone. So thank you for that reminder. Yeah. Okay, copies of the slides. Yes, we'll go out to all of you all. Oh, and then I see about Health Right 360. Just give them a call. Yep, you can do. And then I think the challenge is that the person has to go to Health Right 360 to take advantage of the contingency management. And so really my goal is to kind of get contingency management at all, like a lot more sites, because I think not everyone is able to get out to Tully Road, and that's quite far for some folks. So, okay. All right, I am going to pass this presentation on to Tessa to start talking about naloxone.
Wonderful. Thank you. Hi, folks. My name's Tessa. I use she, they pronouns. My last name's Reynolds. There's another Tessa in the county, Tessa Watson with public health. So I don't mind being misnamed as her. So I work with the behavioral health department in the harm reduction project. So this is a project that we have started through the Q Corner. I'm just giving a little background so you guys know, as service providers, we are also an accessible site for the LGBTQ plus community. We have a drop-in site down here on Center Road. We do a lot of peer support. We do a harm reduction project, which brings me here to the naloxone training to bring that intersection of LGBTQ plus folks and substance use and bringing low barrier access. Especially Dr. Ho spoke a little bit about it, which is with being in behavioral health and medical health, of really an abstinence base and some stigma maybe against harm reduction. So being in, behavioral health is pretty awesome to see the changes in the movement, what's happening within treatment settings. So next slide, please. So we sadly have now National Fentanyl Awareness Day. I cannot talk about naloxone without giving some education around fentanyl and the impact that it's having in our community, especially, folks that are unhoused and may not have access to certain supplies they need in order to stay safe. So at the Q Corner, we do a lot of graphics. So if you follow us on Instagram, we give out a lot of infographics and information and, whatnot. So Narcan does work on fentanyl, right? I've been asked that a lot in terms of that. There is a possibility you might need more Narcan in order to respond to somebody, having them starting to breathe and whatnot. So test strips, this is something that we really recommend in terms of anybody ingesting any type of substance, is really testing it prior. So we do, through my program and in the SHARPS program, which we'll speak, we have fentanyl test strips available through Dose Test and through Dance Safe. They have QR codes on them, which give the directions. It's really about submerging the medication or the substance into water, testing it. It will tell you if it's positive or not. Unfortunately, these tests cannot keep up with all the analogs that are being developed illegally for fentanyl. So it might not catch an analog. So we always want to make sure you have naloxone, or you're, educating folks to have naloxone present, even if the test shows negative, because it could still be potent with fentanyl. And if you guys, want demonstrations or something, you can always come to my site, go visit the Crane Center, and, the directions are pretty clear. So just helping folks walk through those steps. The biggest myth, which is still circulating and causing a lot of harm in the community, is touching fentanyl will give you an incidental overdose. This is completely false narrative. And if you hear this, I really hope that you will speak up on this behalf, because what this does is it is keeping folks from actually responding to folks in need of naloxone, because they may believe, hey, if I encounter this person and they were using, fentanyl and it gets into my skin, then I will have an overdose. That was, really unfortunate thing that the DEA did about kind of putting out scare tactics around it. So it's, since 2017, we've been as harm reduction as, hey, let's get the real information, let's get the science and the facts in it. So, if you have heard that, no fault on you. I believed it in the beginning as well. I saw a lot of media circulating around that. So I just really want folks to be aware. You're able to touch somebody. It does not absorb into your skin like that. There are fentanyl tests, or patches, but that was developed by medical professionals. It wasn't, let's put, fentanyl on our skin and now your pain management is complete. It does not work like that. If you have a laceration or open skin, that could be a different story, because it could get into your bloodstream. So I'll move to the next slide, which is a little bit more on fentanyl. So there's a lot of fake pills. That's something that, really, especially with youth or young people, or if folks are securing their medications outside of the pharmacy, I would really encourage them to test substances, right? We want to test the entire pill to make sure that all of the pill has been tested. There's something called a chocolate chip cookie effect, where if you think of a chocolate chip cookie, we've all taken a bite of one, if you like them, and maybe not got a chocolate chip in your mouth, right? So think of a pill and those chocolate chips are fentanyl, and you test just a portion, it shows a negative, but the rest of the pill may have fentanyl in it. So really making sure they look very similar to legitimate pills. If you see there to that picture, it's really unable to identify which is which unless you test it. Youth are increased risk. There's a lot of, marketplace on social media, this and that. If you guys get a chance, a young guy from Los Gatos High made a wonderful documentary called Fentanyl High, and it's really talking to youth about, the crisis and the scariness of, what the drug sources look like these days. Pill shortages, right? Folks like, hey, they cannot get their Adderall represcribed by their physician, right? They may seek substances on the street, which, may have fentanyl in them. So it's a really strong opioid. So can really, that little bit amount on the top screen, which unfortunately is a picture from the DA, that could actually be an overdose to somebody that is not habituated or doesn't have a tolerance to opioids. So we really want to, be understanding that, like, it really is unfortunate that little amount can impact somebody. And then it's being found, in almost all these substances on the street and whatnot. So just knowing that it's around there. And, when I was working at permanent supportive housing sites, we were testing all the methamphetamine and it was coming up positive for fentanyl. So folks were not actually getting the substance they were purchasing, which is a little unfortunate when folks are, used to certain effects and the way that drugs work in their system. So we'll move to the next slide, please. So what is naloxone, right? Sure, most of you have heard about it. I hope most of you had a training on it, but I'll just do a little overview. So naloxone is a medication that is an opioid antidote. And what it does is it will go into the brain once the opioids go onto the receptor. This medication goes in and it knocks it off of the receptor, and it helps that person start breathing again. The one unfortunate thing about this medication is it can only stay in the system for about 30 to 60 minutes, which is a wide gap there. So we really want to make sure, if we call for assistance, that we encourage the person to get care. If they deny it, which is everyone's right, that if the person that administered the naloxone will actually stay with that person for up to 2 hours, because what can happen is once that medication withdraws from the opioid receptor, they will just rebind. The opioids are still in the body. They haven't had enough time to metabolize out of the blood system. So even without ingesting more substances. So it's a phenomenon called a secondary overdose, which we're seeing more commonly, or I'm actually hearing about it more commonly through participants. So this medication was developed in 1961. I know that may shock some of you because we're seeing it now, out in the community, but it has been gatekept in medical settings in terms of not really getting it in the hands of folks that need it. And we have come to a different place now in 2024 where the Santa Clara County is actually really tirelessly trying to get it in the hands of every citizen, right? Because you just never know when you might need to use it, who you're around, you know, if your child bought something at, you know, school and thought it was safe to take or whatnot. So this is legal. It's safe. It's a first aid medication. It will not hurt somebody if we are not 100% knowing that it is opioid related. If you happen upon somebody that is unconscious on the sidewalk and you administer naloxone, it was a heat stroke, they will have no adverse reaction. Like, it is not a medication that we have to be 100% sure, which I think gives, you know, myself and others a comfort and like, okay, I don't have to be an expert on this. I can just be a good Samaritan and move forward with helping someone in distress. You'll see Narcan, right? That's the brand name. So you might see something naloxone, you might see something Narcan. Naloxone was traditionally made intramuscular and intravenously. Narcan came in as branded, right, to be really user-friendly in terms of a nasal spray. So it's really easier for lay people like us to just administer this versus using a hypodermic needle in a crisis setting. So we can move to the next slide, please. So what is an opioid? An opiate. They're the class of drugs commonly known as like narcotics. There's natural occurring ones like opium, heroin, morphine. There's synthetic prescription painkillers. So this is where I was talking real, you know, securing pain medication outside of a pharmacy is very dangerous at this time. So oxycodone, morphine, codeine, Vicodin, the list goes on, fentanyl. These are all wonderful medications for, you know, pain management. And then the signs of an opioid overdose or event. So what are we looking for, right? What indicates, hey, I might need to respond and provide naloxone to this participant or person. We were going to look for unconscious and unresponsive is going to be number one, right? They're not breathing, or their breathing might be irregular, kind of sound gurgly, like thinking of sleep apnea. Skin color is going to change in the person due to lack of oxygen, right? It'll be blue or purple, gray or ashen, depending on their skin tone. Look around their cuticles, look around their lips. If you're unable to do that, their feet, their toes, their skin is going to be clammy and pale. It can sometimes appear as a seizure. Remember, we had someone we thought was epileptic. They were actually experiencing an opioid poisoning or overdose. And it can also show as vomiting, right? So there's a wide variety of symptoms, which also gives the, okay, we can give it, even if we're not 100%, we don't know, you know? So if we can move to the next slide, and I'll help you guys understand how to use this wonderful product. So what we're going to want to do first is, if we do happen upon someone, they're displaying any of the signs I mentioned before, the number one thing really is they are not breathing, they are not conscious, we cannot get them to respond. So what we want to do is try to get them aroused in some type of, you know, pain stimuli. If we're kicking the bottom of their foot, hey, buddy, can you wake up? Hey, you know, speak to me. Sternum rub, really good, right? Taking your sternums really rough on your, if you do it right now, you'll kind of feel, oh yeah, that's uncomfortable. So that can get someone to winch and be, hey, I'm all right, you know. We also ask folks, please say, I'm going to give you Narcan. Folks that are habituated to opioids and they're using, and it may appear very similar to looking like they're in an overdose, if they know what Narcan is, they know what they're doing. They'll say, no, I'm good, right? That enough can get somebody alerted, because if they are habituated to opioids, this medication is going to immediately put them into withdrawal symptoms, which is not the most comfortable experience for folks that are using substances. So we always want to kind of give them that verbal Narcan, see if they can, you know, become awake. If not, but again, I say, if they do respond, hang around a little bit, because that could change in a matter of minutes to an hour, right? If the medication combines and they get a higher dose in their system. So just kind of hang out. So what we're going to do, we want to take this person. If they're not already laying on their back, please gently lay them on their back. You're going to open your box. It will either look like this, or it can look like this, because we have two different types of boxes. Sorry, my screen share thing is really fun. So these ones are kind of the over-the-counter you're seeing more frequently. We're getting them from NDP. Open your box. You're going to have two doses in there that are going to look like this. You're going to open these doses, one of them at least. Tilt that person's head back, insert it into their nostril until you feel your skin touching their skin. Push that red part in, that will deploy it. You don't need to try it first, it's one dose. Once that happens, step back. Please call 911 immediately. If we're together, I'm with Raj Gill and I'm out in the community. Hey, Raj, will you call 911? And I'm going to give them Narcan, right? So we can get EMS on there. But getting this in their body as soon as possible is really pertinent, because lack of oxygen can cause increased symptoms even following post-overdose. So we're calling 911, we're stepping back. This is if somebody comes to, they might be a little startled, right? They were just unconscious. They have heads around them. We don't want anyone to get injured. So just step back, make that call. This medication takes about 2 to 3 minutes to even work in the person's body. Please do not give one another. All you're doing is increasing the harm for them to have more precipitated and severe withdrawal symptoms. That 3 minutes is a hard time to wait in a crisis situation. If they don't start breathing in about 3 minutes, administer the second dose. Do exactly the same, tilt their head back, put it into their other nostril, and deploy it. If and when they start breathing at any point in this event, we want to immediately turn them on their left side in the rescue recovery position with their arm resting on their head and their knee over. This is if they vomit. We do not want them to choke on their vomit and aspirate. We've kind of defeated our purpose on helping this person breathe again. If they do not start breathing, which would be the most unfortunate scenario, you're going to do your best to give rescue breaths and chest compressions if needed, if there's no heartbeat. If you're unaware on how to do this, you've got EMS on the phone, put them on speakerphone, say, what do I do next? I need to get help and have this person start breathing again until EMS arrives. They're going to arrive, like I said, with intramuscular, with IV, and it might just be a matter of that person getting more naloxone in their system in order for the opioid to, get off of the receptor in the brain. So that is really, I also missed, but we want to say, I'm with someone non-responsive, right? Because this doesn't indicate we have drugs on the scene. We're with folks that maybe PD wants to come and check warrants or what, this is a medical emergency, someone's non-responsive. So things to just housekeeping about naloxone, right? What do we do? It does have an expiration date. Our boxes, they're usually good for a couple of years. So these are November 2026. It has been proven that you can use them expired. It's not best practice. So if you do have an expired box, you're in the neighborhood, or you're near the Crane Center or other various areas in the community, you can get a new box. You want to stay with that person, like I said, up for 2 hours if they don't seek medical attention. You want to know that you can give naloxone to people of all ages, infants, elderly folks. Does not matter, right? This dose works for all ages. It even works on dogs. I've heard from some participants, right, that have maybe gotten ingested some fentanyl and it works on them when they responded. It is legal for all people to carry in California. We're very lucky. We have a good standing order, so there's no prescription needed. You can possess it. A teen can possess it. Anyone is able to use this and give this. There's wonderful, protections because again, it's a Good Samaritan type of activity, not hurting someone. You're trying to save someone's life. So the Good Samaritan's law is what protects us, right? If PD do arrive on scene, they should not be, and I say this should not, because I don't know everyone's experience with the police, right? So I cannot speak for you if you've had negative experiences with the police officers, if they try to give you tickets or whatnot, but the law says that we are not supposed to be citing folks for paraphernalia, for any type of substance use related anything, because these are medical emergencies and we want to keep people being able to get the attention they need. Naloxone is sold over the counter in most drugstores. The unfortunate part is it's very performative. It's about $80 to $120 a box. So please visit your local public health department, us over here at the Collective, and get a box, because that is something that we're going to really want you guys to have now that you have the education and understanding on how to administer this. We want it in your hands. So I'll send a flyer out to the host, and we've made about different places within the area in Santa Clara County. Scoop is a great resource. They will mail order you a box. So if you can't get to us, you can go to Scoop website and they will mail a box to your house. So just knowing there are various ways that Santa Clara County is really making sure that all folks in our community are safe. And I believe that's the last slide. So if you have any questions or anything like that about what we went over. Yes, Roxanne.
I just had a quick question. Can you define poisoning versus overdose?
Yeah, thank you very much, because I do use that, knowing that not everyone knows. Yeah, so they're both right. They mean the same thing in terms of what's happening in the person's body. If they're having adversities, unable to breathe, slowed heart rate, right, an overdose. And then poisoning is what they're referring to. It switched to the language because that's where folks are unintentionally being poisoned by fentanyl, like say buying an ecstasy pill, not testing it, taking it, there's fentanyl in it. So that's considered a poisoning, right? I've taken it a step further, honestly, being in harm reduction work, of really looking at the ways that we use language in our community and how we've separated like overdose to poisoning. Because if I've never once in my 15 years of working in substance use care, have I had someone come to me and say, hey, I overdosed on alcohol. I've had tons of people come to me and say, hey, I had alcohol poisoning. I had alcohol poisoning. And then I've had folks come to me that used other substances besides alcohol and said, hey, I've overdosed. So I've found that as a way that we have structurally let people know, if I think of a poisoning, I'm thinking of a victim, right? I don't think people are intentionally poisoning themselves, right? So when we look at like the ways that, Dr. Ho said something about the war on drugs, right? And how it's really changed the landscape of substance use and criminality. So that was something that I took note of. So I think it should just all be poisoning, right? Or we should have alcohol overdoses. But in terms of this, context of the question, it's about taking the substance and unknowingly know that there is fentanyl or opioids in there. Thank you. Sweet. Well, I will pass it on to Mike Thompson, who's going to give us some wonderful information about the SHARPS program.
Oh, okay. Thank you very much, Tessa. Appreciate that. Was wonderful. I don't often get to sit through one of your Narcan presentations, so it was a treat. Thank you.
Thank you.
Let me see here about sharing my screen for a moment. And I would like to share this one. Can people see my presentation?
Yes, we can all see it.
Terrific. All right, thank you. So the Sexual Health and Harm Reduction Program, or SHARP. I'm going to bounce around on the slide just a little bit. So we changed our name back in 2022 from the Needle Exchange Program to the Sexual Health and Harm Reduction Program. And the main reason why we did that is we wanted to capture the idea that beyond just doing syringe exchange work, we're also now doing a whole range of different prevention efforts. For example, doing testing and providing referrals for treatment for care for HIV and Hep C. We do overdose prevention and education with dispensing of naloxone. And we also do education on alternatives to injection, such as offering smoking kits, booty bumping kits, snorting kits, things of that nature, because certainly routes of administration can have impact on overdose probabilities and things of that nature. We are anonymous, confidential. As you can see from the bottom image there, we've served over 1,700 unique clients in fiscal year 2023. I say unique because certainly from our perspective, it felt like 10 times that number because many of these people are repeat customers throughout the year to our program. Our program is the 4th longest running in California. We started in '94. And we serve all of Santa Clara County. And in fact, later in the presentation, I'll be showing you a map of some of our site locations. We also, in fiscal year 23, distributed over 8,500 doses of naloxone, and we had over 650 self-reported overdose reversals to our program. And on a personal note, since I'm the MAT navigator of the program, since August 21, we've made over 400 MAT referrals. So really quickly, let's talk about what is harm reduction and what it means to people. From my own perspective in my life, I typically like to think of harm reduction as representing safety first thinking for people who use drugs. This can include anything from making sure that that you're using it in a safe environment and have people around you who can respond if anything goes wrong. It also means being able to interact with people as if they're simply engaging in a normal everyday activity that doesn't require any sort of stigma or judgment. When we think of, construction sites and all the safety featured things that people do there, or some of the very, office workplace safety rules and OSHA regulations that we try to operate under here, we want to apply that same sort of non-stigmatizing thinking to safety first or harm reduction thinking with folks who use drugs. What does it look like to do some of the work of harm reduction? Well, first off, I just want to mention that, studies have shown, because we are evidence-based and we try to be evidence-based when doing this, studies have shown that it does not increase illegal crime or drug use in an area. It is very effective in helping to prevent new HIV and Hep C cases and other drug-related harms. It's safe, effective, and cost-saving. We all know prevention is much cheaper than treatment. And it does help reduce overdose deaths. I would like to refer to my earlier slide where we had over 650 self-reported reversals, for example. When it comes to our program mission and core values, of course, it's about providing and improving the health and well-being of the people who use drugs in our county. We try to be client-centered, meeting participants where they're at. That's one of the reasons why, for example, we have not just our stable set sites throughout the county, but we also do a number of pop-ups around the county, roving encampments. You know, when we talk about meeting people where they are at, we are literally going to where they are at. We try to be compassionate without being condescending. Again, we want to be evidence-based with what we're doing so that we can back up everything that we're offering with science and data. We strive to be culturally appropriate. Can I share an amusing story of how this can sometimes look? And Tessa knows about this. Earlier this year, we had Vietnamese Lunar New Year celebration happen at the Cultural Center. And the SHARP program was invited to table. I, thinking that this would be like any other normal tabling event at a health fair or gathering, showed up wearing jeans and a public health t-shirt, my little lanyard. And what I did not know is that for Vietnamese Americans, this is often treated very similarly to a wedding. And so the vast majority of people who showed up were dressed to the nines in formal wear and elegant gowns and dresses. I felt very underdressed for the occasion. Thankfully, I was not alone in this, and many of the other outreach and resource people who were there tabling were also in various forms of jeans, t-shirts, and hoodies. But if I had known ahead of time, I probably would have worn a collared shirt and tie to the event if I'd realized what it was going to look like. So here's the map of our operating locations I mentioned earlier. As you can see from the blue dots, we have 5 fixed locations, including one all the way down in Gilroy. We do pop-up sites throughout the week that are not open to the general public. There's pretty much strictly, many of these are at sites that have restricted access for just the residents of those sites. So we don't typically advertise the location of our pop-ups. And then we also do roving outreach to encampments, usually twice a week if we're able to manage it. This is an image of some of the examples of the services we provide. As you can see, we offer safe injection kits, as well as I mentioned earlier, though not imaged there, alternatives to injection, such as pipes. We also engage in overdose prevention efforts, such as providing fentanyl and xylazine test strips and naloxone, and education on how to use it to our participants. Myself and one of my other colleagues are always present with the outreach team when they're doing their fixed sites to provide MAT navigation and referrals for Suboxone or methadone if folks are looking to do that. We also, of course, are providing screenings for a variety of STIs, and we also offer safer sex supplies as well. We try to take a trauma-informed care approach to the work that we do. Again, it means meeting people where they are at. And another example of that is not trying to have someone progress along a timetable that you think is appropriate. If a person needs to take their time before they go from one stage to another, let them have that, right? And engage in embracing that type of thinking, not trying to force people into a box of our own ideas about what's right and wrong, do no harm. You want to allow people to be who they are at the pace they are. We're all marching through life to a different drum. Celebrating any positive change we can. I don't talk in terms of abstinence. I talk in terms of being happy with your drug use, whatever that looks like for the person who's doing it. The client is the ultimate expert of their life and their use. I listen to them. I don't try to make them listen to me. And if I don't know something that's going on, I ask. I'm not street. I don't know what the latest lingo is or what people are doing. And so it's important to just own up to that and have an honest, open conversation with our participants so and they'll be happy to share with you what they know. And again, to just reiterate, harm reduction and abstinence are not mutually exclusive. Again, this is about the person being happy with their relationship with substances. And if that means walking away from what is a toxic relationship for them, terrific. Does anyone have any questions before I hand this over to my colleague, Roxanne? All right, terrific. Thank you so much for allowing me to present. I appreciate it. And Roxanne, if you're ready, I'll pass the mic to you.
Yeah, I am ready. Do we have slides available? Do we need a break or anything, or are we okay to keep going? Okay.
Joy. Roxanne, can you pull up the slides on your end?
Yeah, I'm happy to. Yeah. Let's see here. 1 second. I just lost it here. Sorry, guys.
Did folks know about these resources ahead of before? That's what we're reading. Or are these new?
Oh yeah, I was wondering too about the NDP if Tessa wanted to talk about the naloxone distribution project really quick too.
I will do that while you find some slides. So what we do
Yeah.
here through either of our departments, public health or the behavioral health, we really are trying to help folks become their own Narcan distribution site, right? So if you work at like a permanent supportive housing and you have access to, 200 residents in your building and they're wanting Narcan and naloxone, and where do I get it? And this person can, you can sign up with NDP, which is the naloxone distribution project through the Department of Public Health. And they will send you boxes if you can identify that you are like an entity that is serving, the public. So it's pretty simple in terms of like, the application process. I've not really heard of people becoming denied. It's really their effort is to get this out in the hands of folks. So thank you, Keen, for throwing that in there. Keen is my counterpart here at the Harm Reduction Project. So they always, got my back. But yeah, that is the site you can go to. And then if you need help, you can always email, myself, Roxanne. We can walk you through it, do a online, meetup and show you the steps to do it. But it's a best way to do it in terms of, I've been short before. We have a training to go to. I've gone to public health. They've let me box it, right? So it's like just having it in mass distribution. Why not, right? Especially since we can get it right now for free from the state and get it in the hands of folks that really need it. Like I said with the naloxone, right? If it's $80 at Walgreens, do you see any of our participants going to buy that? I don't at all. So that's the reality of like, yay, it's here, but it's still really inaccessible unless, you're able to access it on your own or through another free entity like us. And then you guys might also see vending machines popping up in the area, right? If any of you guys, frequent Maine jail or, displaying, a lot of them really started in the jails for folks that are post-incarceration, knowing that, folks that exit incarceration are, I want to say 14 times more susceptible to experiencing an overdose within the first week due to maybe re-engaging back in substance use and maybe even being in there so long that they're not even aware of fentanyl on the streets, right? Like this is, within the past decade, it's really become prevalent. So knowing that there's so many different access points to get naloxone in our community is huge.
I'm almost there. I'm sorry, guys.
It's cool.
I don't know.
Someone in the chat asked, does it make a difference if someone uses a generic version?
No, it's the same product. Yeah, because you might see naloxone just as it looks exactly the same in terms of, the doses. It might be a different color, have a different font on it. There's also a couple more like Revive and some other manufacturers that are starting to make it. I think honestly, seeing the need that Narcan has really been the go-to for folks. But within the public health department too, which I learned when I was working over there, is a lot of folks that are actually like engaging in use and really know, and they've been in this for a while, they prefer the intramuscular because we can actually decide how much to give someone, because like I said in my training, you don't want to give so much in the beginning because it can just increase the withdrawals. What we would like to do is, you know, if 1 cc wakes somebody up, they don't need 4, you know, so like they're really able to give just the amount that is needed to resuscitate that person without, let's say, maybe putting them into precipitated withdrawals. And off to our wonderful Roxanne Butterfield.
Great, thank you. Sorry about that. Thanks for filling in there, Tessa. Just really quickly, my name is Roxanne Butterfield. I'm a community outreach specialist with the harm reduction program. Just some really quick stuff we'll talk about today. We'll do a quick description of some drugs and different modes of drug administration, and then some of the trends that we've been seeing here in Santa Clara County, of like what people are using, how they're using, and then maybe some future stuff too, what we're look towards the future. And then really quickly, if you just want to throw anything into the chat, like why do people use drugs? Yeah, anything, any kind of reason. Let's see what we got here. Coping, I got trauma, feeling good, stress, to feel happier. Yeah, trauma. You may have heard of ACEs. To numb, peer influence, coping. Yeah, stopping withdrawal. Yeah. Great. Yeah, thank you. So people, you know, I bring this up because just so we know, people use drugs for a wide variety of reasons. And there's also kind of a continuum of drug use. It could be anywhere from abstinence, not using or never have used, to, you know, chaotic kind of drug use, and or, you know, experimental in between. And people's relationships to drugs, like Mike was kind of talking about earlier, does change. And so that can go back and forth along that continuum. So, and I bring this up is because, you know, why is it important for us as service providers to know about what drugs people are using? And, you know, some of the main reasons for that is so we can offer better services. When, you know, folks are coming to us to, you know, us wanting as service providers wanting to engage folks with various programs, not being able to relate or sit there and listen, you know, to folks isn't going to get that engagement going. So really being able to want to build trust and rapport, understanding what people are talking about and showing compassion around that is important and helps us do our jobs better. So I can see next slide. Here we go. So just a couple of, and Tessa did a really good job about talking about different kinds of drugs too. So we have what we call downers. And so those would be kind of like your prescription pills, heroin, methadone, benzodiazepines. So that would be like your Xanax, Valium, Klonopin, and then alcohol as well. And then other things you might hear will be like stimulants and uppers. And so that would be your methamphetamines. For pills, it could be like Adderall, and then cocaine and crack, which we usually put that together because generally the only difference between cocaine and crack is mode of administration and baking soda, really. So some other drugs that you might hear about when talking with folks, you got your kind of club drugs, so ecstasy, MDMA, DMT, and then, you know, lots of people smoke marijuana, inhalants, so that would be like your huffing, so or solvents, so like something out of a can, like the air spray for your computer, gasoline, and then poppers is another one. Here's some of the data that we have from our program from last fiscal year. So, and this is self-reported from participants. About 70% of them use methamphetamines. And then we have about 25% using heroin only, and then 17% heroin and methamphetamines. And then we have fentanyl, just fentanyl, 10%, heroin and another opioid, 5%. And I imagine that this is going to change a lot this next round when we get our data going. We'll see an increase, just narratively, I can tell you right now, we'll see an increase of fentanyl, and then an increase in fentanyl and methamphetamine use as a using together. You guys may have seen this. This is the 4 ways of overdose deaths. And I bring this up only because this trend also reflects Santa Clara County and the drug use that we've seen and are seeing today. So in the late 90s and early 2000s, that was the first wave when we saw prescription opioid overdose deaths. And so a lot of needle exchange clients at that time and clients of yours were using prescription pills. So that was your oxys mainly, and Vicodin or Norcos. That kind of went away and was harder to get for people. So a lot of people switched to heroin. So there was an increase in heroin overdose deaths. And then the third wave is when we talk about fentanyl. So that kind of started around 2013. At first it was fentanyl in the heroin, and then also fentanyl patches were really popular for a while. A lot of times people would get those and they would like gum them in their mouth. So when we were doing overdose and naloxone trainings, we would always tell people to check people's mouths in case there are patches in there. And now we see fentanyl being sold and used just by itself. And so that kind of continues with the 4th wave, which is like polysubstance use. So I'd say narratively about 75% of the folks that come to see us that use fentanyl, 75% of them use methamphetamines as well. And the modes of administration are really important when talking about overdose risk. Majority of folks are smoking fentanyl. Some do inject, but yeah, smoking fentanyl and smoking methamphetamines. And this really, the modes of administration and the drugs people were using really helped steer and kind of guide our program development and our procedures and the things and the supplies that we were offering, because we realized and recognized that less and less people were coming to get syringes. And we started talking to folks and listening to them, and they had switched over to using fentanyl and were smoking, so they weren't getting syringes anymore. And so that really helped us kind of develop our alternatives to injection kind of component of the program. And so we started offering pipes and foil, so we could really have folks kind of return to us and come and get Narcan and come and get those supplies, so we can keep people engaged with program. So that's a lot of all the supplies we give out are legal, and they really we're given out for a reason, whether they're for HIV prevention or overdose prevention or abscess prevention, but they also help us kind of they act as a hook basically for people to come and see us, so we can spend time with them and build rapport and keep people engaged and not isolate and stuff, so they know that they can come here to get supplies as well as talk to us about treatment if they're ready, and or talk to us about housing, or talk to us about where to get showers, things like that. So what are we seeing now? I just talked about, we're seeing about methamphetamine, smoking and injecting. So majority of our clients or participants are doing that. A lot of fentanyl, people using just fentanyl, partially because it's a lot cheaper and it's just easier to get. You kind of get, I guess, you get the way fentanyl feels generally is it impacts you faster. So you get kind of like more bang for your buck. But the downside of that, one is it is stronger. Two, it's kind of being made in not it's not FDA approved, I should say. So it's like you don't know exactly kind of what you're getting. Like Tessa talked about the analogs, so they're constantly changing the way that they make the fentanyl. So a lot of it's just like a random white powder that you're getting. And so that also leads to overdose. People may think that they're getting methamphetamines, or they may think that they're getting cocaine. And it could be, the dealers don't know, a white powder is a white powder is a white powder kind of thing. So we're also seeing a lot of xylazine. And xylazine is it's a sedative, an animal sedative, and it's not being used by itself. It's being put into the fentanyl, and it does not respond to naloxone. So that's kind of one of the things that we, as a public health department and service providers, worry about with folks using that. We've seen a lot of it on the East Coast and the Midwest. And usually as drug trends kind of go, they tend to start in the East Coast and work their way over to the West. And so, luckily for us on that end, we're able to kind of prepare for the different kind of waves of drug use that happen. So we just recently started giving out xylazine test strips. And so we really encourage people who are using fentanyl to test that for xylazine. And then also polysubstance use. So mainly methamphetamines and some kind of opioid, primarily fentanyl or heroin and methamphetamine use. And a lot of that is because fentanyl is just so strong. So people weren't wanting to just kind of be nodding off all day. People have work to go to, or families to take care of, things to do. So using methamphetamines sometimes makes your body feel kind of negate that. It does increase overdose risk, though. I do like to point that out. So that is kind of one myth that we try to dispel, is that if someone's overdosing, you may have heard like, just shoot them with cocaine, or, give them some methamphetamines. That doesn't actually work. If it did work, it was not that working. It was something else. And so that's actually just kind of making your overdose risk actually increase, because it's making your heart work harder. So there's that kind of something to talk about with folks. I'll skip over this case study. We talked about future analogs. So this is something that's been coming up. It's called, it's nitazines, and it's an opioid also. It's not legal here in the US, but people have been getting it, over the internet. You can get it kind of mailed it to you. And then it's also kind of being put into, it's another one of those like white powders or white, colored pills. So some street names could be ISO or clear, or clean, excuse me, would be some other words for it. There hasn't been too much out here, but participants have told me that they have been able to buy it. And a lot of times, I keep talking about just the white powder because that's generally like, there's just so many different powders out there. And so a lot of it's like marketing, marketing something ISO so someone can charge more money for it because it's stronger, or marketing something as fentanyl because it was stronger than heroin kind of thing. So that's one of the reasons why they used to have colored fentanyl, was because someone could sell the yellow fentanyl because it was stronger than the pink fentanyl. And it was a way for dealers to keep, track of the different kinds, the different types of drugs that they had. So, but that's kind of no longer out there. So now it's all just white powder. Do we have any questions around fentanyl? Nitazene, also gas station heroin, is another slang for it. Trank was xylazine and fentanyl. That kind of came about because fentanyl doesn't last as long in people's bodies as heroin. Heroin's usually 6 to 8 hours. Fentanyl is usually 4 hours. So people were having to use more often to avoid going through with detox or withdrawals. And so by putting xylazine in the fentanyl, it kind of gives it what people call legs and makes it last a little bit longer. So that's that. So policies, it does affect us and drug culture. You know, some of the policies that came around for fentanyl was, you know, not being able to get synthetic and FDA approved fentanyl from China. And so that's where we came up with all these analogs and, you know, people thinking they're scientists making, you know, backyard fentanyl kind of thing. So it's, you know, important to kind of keep abreast about that stuff, as well as, you know, policies around paraphernalia, policies around selling fentanyl. You know, a lot of DAs are, you know, going after people who are selling fentanyl, putting harsher, you know, crimes upon that. You can think back to, you know, the 90s when there was crack and cocaine, and there was a big difference of, you know, with the war on drugs. And if someone was selling 5 grams of crack, they would get the same sentence as someone selling 500 grams of cocaine, kind of thing, even though it's the same drug. But really only affecting people who, mainly the African American community, and people who could only, you know, afford $5 versus $500 of cocaine. So that's kind of that. Are there's any other questions? I could, you know, talk about drugs all day long, to be honest. Different modes of administration, I think, really matter. You know, snorting, injecting, and smoking, they all affect the body differently, hit the body faster, come with their own kind of risks. You know, injection has abscesses, so we always try to abscesses and HIV and hepatitis C. So anytime that we can talk to someone about transitioning to smoking or snorting, we, you know, try and work with someone around that. You know, a lot of times people go to injection because it's cheaper. You don't need as much of it. So, you know, drugs can be expensive. Oh, Tessa, you got your hand up.
Yeah, can you share with us, does naloxone respond to xylazine?
Oh, thanks. Yeah, no, it doesn't, unfortunately, because it's not an opioid. So yeah, but we still encourage people to, even though if you think there might be xylazine, you still want to use naloxone on the person, just because it will affect any kind of opiate that's in the person's system. So they still may be kind of sluggish, and that's one of the reasons why we still want people to call 911 and go to the hospital. Yeah. Any other questions? Great. That makes it easy. Okay. You guys are always welcome to come visit the harm reduction program. We have a big bus that we go out on. You can always, yeah, come tour. We also work with community partners to help out with any kind of assistance on getting on the naloxone distribution project. Or if you want to give fentanyl test strips out to clients, you can always come and we'll give you, you know, we have a huge supply of fentanyl test strips. So if you would like to have some of those to give to your folks, come see us and we'll definitely get those to you. And as well as xylazine test strips. We have some of those as well. So,
There's a
Uh,
question in the chat
oh
that
yeah,
is what is available for cannabis reduction from this program?
we don't have anything right now for that. I'm not sure if the MAP program has anything for that. Yeah, it would really kind of, right now, we just would have working with someone around tapering would be the best thing that we have available right now. Mike, do you have anything?
I see Sarah asking if xylazine test strips are available through NDP.
They're not available through NDP, but we do have them that we'd be happy to share with you.
Is there, like, should we put a link where if community partners want to order some of the xylazine or the fentanyl test strips? Do you want me to put the harm reduction email?
Yeah, that would be great. Yeah. Yeah, so we'll put the harm reduction, it's our general email, and so feel free to email that and we can get you those test strips. And they're great. It's kind of an all-in-one package. So it has the instructions and what to do with the results and how much water you need and how much of the substance you need.
Can I just add too that we're always open for like feedback from you guys, what you're hearing in the community, what your participants are telling you. That's a lot of how we get some understanding of like, oh, this area, they're seeing a lot of xylazine, or, you know, it's really participant based because they're kind of out in the field investigating and doing work on our behalf that we can't do. So, you know, if you hear a participant tell you this stuff, please shoot us an email. Like we just had someone from PATH tell us all about, and we were like, cool, that's helpful information.
Yeah. Great. Should I stop staring? Stop sharing.
Yeah, if there's no other questions, we can end it a little early. I just want to thank you all, Dr. Cheryl, Michael Thompson, Tessa Reynolds, sorry about the wrong name earlier, and Roxanne for joining us today and presenting. And just to update you all the training slides and recordings will be available on the CoC website, and we'll send out an email to the CoC SBN listserv when it's posted. And then in the chat, I also put in a survey that you can all just take a moment to fill out just to give feedback on how you like today's training. And if we still have some time for questions. So if you have questions for any of the presenters, please feel free to come off mute and ask your questions.
I have a quick question for Dr. Ho. Are there any regulation in terms of the medication-assisted treatments that clients can be taking when they enter into a residential treatment facility? Like, are there some residential treatment facilities that will prevent clients from taking other medications versus another?
A good question. Sorry, I have a little bit of echo. Let me see here. So they should all be able to take all the medications. I think Pathways has the most experience, and we have definitely kind of people can take methadone and be at Pathways. I believe that is also the case for Muriel Wright. So yeah, I mean, methadone can be in, and then Suboxone and all the other sites. So all of these are county contracted sites. They should be able to take the huge spectrum. I know that some of the kind of private, maybe some of those, you know, kind of other organizations that are not contracted with the county, there may be limitations of bringing in methadone or Suboxone, but not at these sites that we talked about today.
Thank you.
You know, something I found interesting, we had a gentleman on dialysis, and he was unable to access residential services in this county due to the inability to go and get his dialysis treatment. So that was something, it's not in lieu of your question, but that was just something to keep mindful of, where I'm like, oh, if I'm working with a patient in dialysis, we're navigating outside of the county.
I see a question in the chat, someone trying to get MAT, but they were testing positive for things. You know, this probably, my guess is, came up in a methadone clinic scenario, as opposed to sort of like a, you know, for buprenorphine or Suboxone. You know, I think different clinics have different perspectives or viewpoints on other medications. I mean, I think, or other substances. So for example, in general, the kind of the way of thinking now is, you know, if you are testing positive for the, so for example, if I'm treating you for your opiate use disorder, we're treating only your opiate disorder. If you're testing positive for, say, methamphetamine, well, we're not providing you treatment for that. And so for low barrier clinics, that's not an issue. We may just, you know, kind of provide you more support. But I will say different clinics have different approaches around that. And so my guess is that's probably the scenario in which that occurred. And so, you know, I will say that for the methadone clinics, there are 2 players in the county. There is the county, you know, 3 sites, but there is also the BART in Menlo Park. And so again, different clinics have different perspectives. And so, you know, it's good that we have different options.
I'll just add something too. If your participants are on Medi-Cal through Valley Medical Family Health Plan, they are able to access a cab. So I had a lot of folks that would like use their taxi cab to go to Menlo Park every morning to get dosed for their methadone, right? So like knowing that like there's so many barriers in accessing services, as we know, especially when folks are unhoused, that like was that they would literally show up and knock on the dude's door. Hey, let's go, you know. So it's a really great service if you're thinking like, oh, wait, how do I even access and get this person care in another area? The cab service really a go-to for those type of situations. Thanks, Chloe, for throwing that in the chat.
If there is no other questions, we can end early. And again, thank you all for presenting today. Oh, sorry, one other question from, can you use the Medi-Cal to go to residential too?
Yes, so all of the services we talked about today are for Medi-Cal recipients. So yes, Medi-Cal covers residential and detox.
In my experience too, is if they weren't able to get a cab, sometimes the provider at that place might have a taxi voucher or a way or some type of transportation to go out in the community and bring them in. So that's always an ask too if you're on the phone with one of the staff members.
Well, if there's no other questions, again, thank you all for joining today. We really appreciate your presenting and the training on substance use and treatment services in Santa Clara County. And for everyone who joined, please look out for an email where I will be sending you the slides from today, and then I'll email the listserv once the recording is posted on the CoC website. Bye.
Thank you all. Take care.